Hi everyone, welcome back. It's been placed on my heart to discuss a topic that's very serious in nature, something that definitely hits close to home to me in my personal and my professional life. I know I usually get on here and I talk to you guys about a variety of topics as it may relate to alternative sexual lifestyles, like BDSM and cuckolding and interracial relationships, dynamic. I get on here to talk about race politics, right? One of my favorite inspirations is Dr. Umar Johnson, um, who is a Pan-African. He's a school psychologist, a world-renowned, shall I say, clinical psychologist. So it's someone who I look up to as a mentor. Um, and as myself, as a clinical psychologist who works in a state psychiatric facility here in New York City, I am exposed to obviously a lot of individuals who do suffer from some very severe mental illnesses, to say the least. It's not my first time working in a psychiatric hospital. I first got into mental health back when I was very young, right? So I graduated from Florida State University at the age of 22 back in 2006. I took my very first job in mental health. I was working at a state, or not a state actually, it was a local city psychiatric hospital for a short-term stabilization. I believe it was my junior or senior year. So I was very young, like 21 years old. I took my first job post-undergrad when I returned back to Jacksonville at the age of 22, working at a residential lockdown facility that housed a group of youth ages 5 to 17 years old who were wards of the state of Florida, right? So kind of just to set the context for what I'm going to be talking about here in this video, to show that I do have extended and substantial experience working with this particular population. So I'm going to be talking about treating individuals who do suffer from a diagnosis of PTSD or borderline personality disorder or dissociative identity disorder, or a combination of all the three, right? It's funny enough that I actually have some patients on my caseload who have been diagnosed with all three. It's very serious, okay? So I'm going to take my time here with this video. My voice, I kind of lost my voice like over a week ago, and it's slowly coming back. So if you guys notice, and sometimes I will clear my throat periodically through this video, so don't mind me. This is a topic, as I said, like it's very personal to me, especially myself having experienced trauma. And trauma, for those who are not aware, it can come in many different forms, right? When you think of trauma, some people think of trauma related to veterans who have gone to war, who've been in war zones, right? And they come back to the United States, which in fact, that's where PTSD actually was coined, in working with those individuals who had been sent to combat and do war. And then over time, research evolved and we got a fuller picture of how trauma manifests itself, not only in combat veterans, war veterans, but in your day-to-day people, right? Your day-to-day average working people, and even in children especially. And I think it goes without saying that it's very important, it's very vital that as helping professionals, for those who are watching this video and you do work in the field of mental health or in the context of the healthcare system, it's very vital that we take into the proper context trauma in of itself and how it shows up in terms of the symptomology that presents itself in individuals who have experienced life-altering events, right? And more especially how we as clinicians, as helping professionals, work and treat these individuals, right? How we interact with them. Because if we're not careful, right, and if we're not taking a trauma-sensitive approach and working with these individuals who suffer from PTSD, which oftentimes kind of evolves into these personalities, lifelong personality disorders, including borderline personality disorder or dissociative identity disorder, we can actually cause more harm. And we all know that within the profession, there's an ethical code that we must adhere to. Ethical and legal code standard of practice that we must adhere to. I know a lot of people, once they kind of get their footing, right, in the field, and they're working in the field for so many years, they do develop, there's this thing called compassion fatigue. People get burnt out. This work can definitely have a detrimental impact on us, right, as helping professionals. So that's why it's always important that we be mindful of how our work is impacting us, right, on a psychological, emotional, and physical level. As I was going through my PhD program back in Los Angeles from 2016 to 2020, my first 4 years, before I moved back to New York to complete my final year, my pre-doc internship, it was heavily emphasized, right, the importance of being mindful and practicing mindfulness, being self-aware, right, turning the focus back on us, because we are the one being used as a tool to further improve the quality of life for people who have entrusted their care in our hands. This is very serious. Now, where I work, some have entrusted, and some, it comes by no choice of their own because they have been committed involuntarily for an indefinite period of time to a state hospital. I take my work very seriously. I shared a video yesterday, as you guys saw, where I was back in Los Angeles. I was working at my very first clinical rotation, where I was working with a group of adult individuals who live with developmental and intellectual disabilities, comorbid with mental health diagnosis, right? And I was sharing a story of how my heart, got heavy in seeing how these individuals become vulnerable and subject to potential abuse. It happens because people become negligent of the needs that these individuals present themselves with. And not only that, sometimes people are just ignorant, right? They turn a blind eye. They're not properly and they're not properly well trained, right, to work with these individuals. And then they come with their own stuff, right? So the thing I want to note here is that what I noticed in working with individuals who suffer from trauma-related symptoms, right, that may evolve into a full diagnosis of PTSD, is that they can have the tendency to pull you, right, to draw you into this enactment. And I'll give a few examples. I remember when I took my first job post-undergrad as a residential counselor back in Florida, it was like my first day, if not maybe the second day. I know it was in the first week, right? And this is working with a group of young male children, ages 5 to 17 years old, who had become wards of the state of Florida. And I remember I was obviously new to the unit, right? Because the way the place was set up, there were different cottages where the children lived. And the cottage, the unit where I worked was sexually reactive. They call it sexually reactive because many of those young children have been sexually abused. And in turn, with the cycle of abuse, they become abusers, right? And they're hyper focused on sex, right? They're very sexually preoccupied, and it shows up in their behaviors, inappropriate sexual behaviors. But not only that, at the core, these are all children who had suffered from abuse at the hands of their caretakers. Sexual, physical, emotional, psychological abuse and neglect. So it's always important, you guys are going to hear me talk about that throughout this video, and putting things into that proper context. I think that it's very easy, if you're not careful as a helping professional, to become mindless, and forget the historical context that serves as a template, right? As the sounding board for these behaviors that we end up having to deal with, right? Which, I work amongst an interdisciplinary team of professionals, clinical licensed professionals, and I even see how they have become burdened. And it's very easy in that process to forget, right? That these, first and foremost, are patients, right? They are here for a reason, right? But it's like they come into the workplace as if they're just going out into the streets and coming across your random Joes on the street. And how do people treat random people on the street? With disregard, not with consideration, right? Of what helped to shape this individual, the traumas of this person, the history of this person. Doesn't matter, right? Because when we're out in the community, we're all people navigating the world, right? No one really takes the time to think, oh, this person is dealing with something. This person is suffering with something, right? Everyone is focused on themselves, right? Without consideration for the next person. However, when you're working in a certain context, especially in a clinical setting, right, where you have been bestowed the responsibility under the auspice, right, of your licensing body to do no harm, to do well, to do good by these people, then it's your obligation, it's your duty. And even in the video that I reposted yesterday, right, for those who follow my Facebook page, and I left the caption that I've always been a patient advocate. That's just me. Like I said, I have direct personal experience with a lot of things that the patients present themselves with, right? I'm not too far removed from them, right? So I relate. And going back to the story of like my first week working at the residential facility, I remember, I think I was standing in the kitchen area, and a child, at the time, I think he was like 12 years old, but he appeared to be younger than his stated age, right? He was in the living room, and I mean, like a split second had passed by, and I just, out of nowhere, found a pillow meeting my face. Boom. Now, granted, a pillow, right? How much harm can a pillow do physically? A pillow is not going to really harm you, right? You got kids, sisters, brothers, siblings, they have pillow fights, right? Because it really doesn't, it's fun, but it doesn't cause harm. But for me, when it happened and the pillow met my face out of nowhere, I looked up and I saw where it came from. It came from this 12-year-old kid who later became one of my favorite patients or clients at the time that I was working with. And I look at him and he has this mischievous, evil looking smile on his face. That's how I saw him. I'm like, why? And I think it was more emotionally harmful for me to see that he thought it was funny. It was a game. And in that moment, I learned a very valuable or invaluable lesson in working with this population who suffers from trauma, significant amounts of trauma. And I'm young, so this is, for me, it was not that costly, granted, right? It was just a pillow. It wasn't a costly lesson, but I really appreciate the lesson there. And mind you, like I said, this was like my first week on the job, post-undergrad. Like my second job, right? The first was I was working as an intern, like my junior year at a psychiatric hospital in Tallahassee, Florida. And tears began to come down my face. Number one, I felt embarrassed, right? And shocked and a bit confused, like, okay, what do I do? Thankfully, of course, I was surrounded by a group of people, men, like I think all of the other staff there were men. I was like the only woman, one of which, actually I think it was another one, older woman working there. But women really didn't take that kind of job, right? We're working kind of in the trenches, direct care with children who have severe trauma histories and therefore are, can have the potential to become violent, physically violent. Not just the potential, but they are. That's just real. They are violent. And like I said, my immediate reaction was an embarrassment. But then the staff ushered both of us into the other room, right? The larger kitchen where we had a talk. And I'm very thankful that this conversation happened, because it let me see that, you know what? It's not about me. I should not have taken that personal. I think my initial reaction, especially being an amateur, somewhat, relatively speaking, in the game, is that I initially took it personal. And I talk about this particular experience because there are, and I've seen it, I continue to see it where I work, and this is many years after, right, that experience, but I see professionals, people who have been working in mental health for years, and they respond in ways that they're just amateurs. Like I said, I'm grateful. I look back, I'm grateful for that experience, because my process after that happened, I was very mindful of my process, right? And I had to take a step away and to see, like, well, this isn't about me. This isn't personal, right? This kid is acting out of his trauma. And we're going to go into this topic very deep, right? To kind of peel back the layers of what trauma is and what it looks like, how it manifests, and how we as helping professionals can respond to trauma in a healthy way, in effective ways, right? Because otherwise it just makes things much more difficult. And so, like I said, he later became one of my favorite clients in working there, because number one, that was the first and last time. And I think what was effective was that I took some time out. I had a chance to have a mediation with a well-seasoned staff who brought us to the other room. And we talked, and the kid apologized. This is a kid. But this is a kid who also has developmental delays, right? I later taught him how to read. Didn't know how to read at the age of 12 years old. And it's like, Through that process, I began to learn more about him and to appreciate who he is and to put things into the proper context. Now, is throwing a pillow at a staff or anyone for that matter appropriate? No, it's not. It's inappropriate behavior, so it's not to excuse the behavior. And I think that's where a lot of people go wrong. I've seen it in my colleagues that I work with, right? They come to this stance to make an assumption of saying, oh, well, you're placating the behavior, you're making an excuse for the behavior, you're babying them. It's no. Being trauma focused and coming at this with a trauma sensitive approach is for the client, for your patient, but it's also for you. Because you'll see when you implement this approach, when you utilize it, it makes for a healthier relationship, which is of utmost importance when it comes to psychotherapeutic treatment. There's no treatment without a healthy, sustainable therapeutic relationship. So you have to have that there first. And like I was saying, in working with individuals who suffer from PTSD, they will pull you into an enactment. That's essentially what this kid was attempting to do, to pull me into an enactment, to see. It was more about cause and effect, to see, I'm testing her. How is she going to respond? Notice it was a pillow. It wasn't a shoe. It wasn't a hard, solid object, right, that could have caused some damage. It was a pillow, a soft pillow. I think that was very deliberate. And I think it was his attempt, as I reflect back then when it happened, it made me think like he was testing. And patients, we know they do that. They test, right? It's a way of getting to know a person. It's his way, right? It's dysfunctional, but it's his way of seeing, like, how is she going to respond? Is she going to be angry at me? Is she going to cry? Is she going to hate me? Right? Is this going to negatively impact our relationship? Let's see, because that's going to determine then how he's going to interact. That lets him know, first of all, what type of person I am. Can he trust me? More importantly, because trust is a precipitating factor to building that solid therapeutic relationship, right? To building rapport. And yes, he learned that he can trust me. I did not retaliate. I did not hate him. I had no bad feelings for him. If anything, it made me want to learn more. It made me want to be more careful and delicate, right? And seeing like, okay, there's something there. I had to take myself out of it. I had to set aside my feelings. Granted, like I said, I did cry. He saw my tears because that's just kind of therapist I am. Like, I'm very transparent, you know. I embody a humanistic approach. I think that's very important so that my patients, my clients see I am a human being, right? So yes, he saw tears. And even through the tears, I mean, he still had a smirk on his face. But my reaction was not hatred towards him. Whereas some, especially seasoned staff, right, who are burnt out, who suffer from themselves compassion fatigue, they don't have that level of tolerance to tolerate that type of thing, right? And they do retaliate. They do shut down, right? They don't want to have anything to do with that patient. Granted, this patient is under your care, but that wasn't my approach. If anything, like I said, it was the beginning of our relationship, and he had never hit me after that, ever hit me after that. We had a great relationship moving forward. I think that story is very interesting and is very significant to my development as a therapist and then now a psychologist years later. Again, this happened when I was 22 years old. Back in 2006, I'm 39 years old now. And so in terms of enactment, right? Because the thing about people who suffer from trauma, let's talk about trauma for a bit. Right? I talk about how when people think of trauma, they think of, combat war veterans. People may think of natural disasters like hurricanes. Like when we think of trauma, we think of the images that we see on television, right? That are broadcast to us and people in pain and suffering, right? Clearly that's trauma. That's something that changes one's trajectory. I always say this, that people who experience trauma will never be the same, right? It changes everything. And yes, there's treatment for people who suffer from trauma, but they will never be normal individuals, normal, so to speak, right? The way they process information will forever be different, right? Because the thing about trauma, it has a neuro, biopsychological impact that's lifelong, that's irreversible. That's just what it is. I think if people understood, because I'm thinking about, when I say people, I'm thinking about the people that I actually work with. And I'm going to give an example of a few patients that I work with who suffer from PTSD, borderline personality disorder, and dissociative identity disorder, which was formerly called multiple personality disorder. But I think it would be helpful, and I'm glad that as part of my PhD program, my training, we are required to take a class where we understand the neurobiological aspects of mental health, right? And I think when it's framed in that context, people are more compassionate and more understanding of the behavioral manifestations of the symptomology that patients suffer from, right? So they're not looking at it through a strictly behaviorist lens to say, oh, you need to get your act together. It's not as simple as, all right, you do this, so you're going to be punished. Point blank, period, as if, number one, they're criminals or not. I mean, granted, some have committed crimes, but is that the clinical lens that we should look through? I don't think it's fair to look at it through that lens and treating these patients as if they're criminals. Mental health is not a crime. If a person suffers from a debilitating mental illness, that's not a crime. Why are they being treated like that? Now, granted, there is an intersection. It can be overlap. Where I work, given it's a state psychiatric facility, there are some patients who have been committed for a crime, who are committed to the hospital for crimes that they commit. However, they were found not guilty by reason of mental defect, which was formerly called the sanity plea. Some have committed murder. Some have committed some very heinous crimes, right? But at the end of the day, if they were found now not guilty, that in and of itself tells you that how we should treat them, how we should interact with them. This is a mental illness, right? If a person suffers from any type of condition, health condition, whether physical or mental, right? I think there should be given a certain level of consideration and care. That's just me. That's always going to be me, right? And I think that's where there's a divide that happens between me and my other colleagues who I work very closely with on the team. And granted, I think that it's very healthy that we don't all think alike, right? Yes, we work on the same team, because on each ward at the hospital, there's a ward psychologist, there's a psychiatrist, there's a social worker, there is a treatment team leader, there's a psychiatric nurse, there is a medical specialist, right? I don't think that we all should think alike, but I do think in order for us to be effective, we should operate under the same approach, right? I think that we should operate within the same paradigm, that we are on the same page, right? With a very important respect to where this patient's behavior is coming from, what's motivating a person's behavior. And delving deeper and looking at trauma and how it shows up. You can tell, I know I can tell, right? You can pinpoint when a person has experienced trauma because oftentimes there are triggers. There are triggers that are known to this person and unknown, right? And it may seem like things that ways in which they're reacting is like this, it's coming out of nowhere. You're like, what the hell? We were good. Like, what's going on? Right? It's coming out of nowhere. But I would like to believe that there always is a trigger. It's important to know, though, right, what those triggers are. And again, there are staff who don't know. I work on multiple wards there, right? My primary ward is all men. But I've also worked on the DBT, as they call it, or all women's ward. And I communicate with my fellow colleagues, right, on other wards that I cover. And I ask them, and this is just really in general, like, you know, what's the trigger? What kind of, and they're like, I don't know. You know why they don't know? Because they have not taken the time to get to know the patient. And there are a lot of people who really don't care about getting to know the patient. And it comes at their own detriment. Believe it or not, that's what ends up happening. It makes their job 10 times much more difficult. It's sad, though, because guess what? Think about patients who suffer from trauma. They're hypersensitive. They're very hypervigilant for good reasons, for maladaptive reasons, right? It's maladaptive, but it's adaptive in the sense that it served a purpose in that point in time when they were experiencing the trauma. And they pick up on those little nuances and ways in which you communicate with them or miscommunicate, interact with them, misinteract with them. They know. Staff that are there for a paycheck and a pension, and the staff who really care and have compassion for them. They know. They notice the subtle differences between staff and within staff, right? They can tell when things change. They know. And they react to that. They respond to that. I do take the time to get to know my patients because I genuinely do care. I genuinely want to know them. I think that's of paramount importance. If I'm going to be effective as a clinician, I need to know them, their histories. Yes, I can read what's written in their chart, but I need to come face to face with this person to know, who am I working with? Who are you? Right? What are your triggers? There are patients there where I work currently now. When I say who have suffered severe amounts of trauma, I mean severe. First-degree burns by their parents, biological parents. Neglect. Going back to the kid that I was working with at the residential facility in Florida, he was abandoned by his mother at birth, placed in a dumpster, left to die, and someone found him. I can't make this up. These are the individuals that I am fortunate. That's how I look at it. I can look at it. It's a blessing for me to be able to work with them. And I just was out shopping yesterday. I ended up in Times Square. Sometimes do that. I'll take walks and I end up places, right? So I ended up in Times Square and I ended up stopping at Forever 21. And I picked up several items which I wanted to try on. There was a line to get to the dressing room. And I began to kind of share my thoughts out loud about, how disorganized that place was because they had multiple fitting rooms, but only one was open. And the lady standing in front of me, she happened to be a Black woman, and she looked back and she was in agreement with me. And then we began to talk, right? And then, she shared with me, her profession, what she does. She's a dancer, and she talks about how important it is for her to stay active. And then I, of course, shared with her what I do, right? And I'm a psychologist. And she's looking at me when I tell her, the setting in which I work. She was like, that has to be very difficult. And I said, yeah, it's going to be very challenging, but I'm made for this. I truly believe that. I fit there like a glove and working the work that I do with the patients there. It comes so natural. And for me, it's effortlessly. It's very effortless because, not that I don't put effort in, but I do it with such ease and grace that, it's not like I'm going out of my way. This is something that comes natural. Everything that I've gone through in my life has prepared me for this moment to be able to be an effective change agent in the lives of these individuals. That's what I mean by I'm made for it. And so it's very unfortunate that none of us, number one, chose to be here, right? And in the same vein, none of those patients chose to have to experience all of the trauma that they did. But then, if you were to go there, if only you guys could just get a bird's eye view, right? Or be a fly on the wall and see what happens in these types of facilities, much of which is reported, definitely, to the Justice Center. Because it's really abusive. It's like more abuse is perpetuated on top of these individuals who've already had a very fucked up hand that has been dealt to them. And it's just like, y'all have to be the most diabolical. How did you even get this job? Granted, they need people there. They're desperate need. Detrimentally short-staffed. I get it. But it's just like they're not qualified. It takes a special kind of individual to work with those patients and to deliver proper care that they need. I mean, many of the staff are offset patients, 40 and slip, but they themselves really need help. They're insensitive, what I've seen. Insensitive, unempathic, they just don't care. And then when you look at the race, right, because everything is contextually understood, and we're talking about an overwhelming number of patients there represent Black people. Black people are overrepresented in mental health, right? No surprise, because it's the same thing in the criminal justice system, and the prison system. And when you look at the demographic of the staff, granted, they are melanated people, but they're Indians, like East Indians, some white, some Caribbean. And on the surface, one may say, oh, well, they could be the perfect fit because they have a certain skin complexion. But no, what is their cultural background, right? What is their ethnic background? Do they even really identify? And that's where we begin to talk about race politics, right? And when you carefully examine and study race, especially here in America, you will see that the Caribbean Black person experience is different. And they even see themselves different than us, as we're all descendants of enslaved Africans, right? But they're like, oh, we're not them. We're not Black American. The same thing for melanated East Indians, right? They don't really identify as Black. They're not one of us. So, do you think that those people care? And if you see the division, you see, okay, this is where the line is drawn. I see it through conversations that I create amongst my colleagues concerning the patients there. Granted, yeah, many of those patients are difficult. They're challenging. They're there for a reason. I get it. But it's like it makes matters worse when you're very insensitive. And when looking at trauma and how it manifests, and we're talking about, okay, being able to identify triggers and early warning signs and knowing where that's stemming from. And when you look at, as I mentioned, different types of trauma, and then contextually and culturally, socio-culturally, there is racial trauma, there is intergenerational trauma, there's childhood trauma, which is a really big one, right? Because many of the patients there suffer from childhood trauma, layered by, unfortunately, racial trauma, intergenerational trauma that's passed down in their family. But zeroing in on childhood trauma, these are individuals who suffered abuse from the very people that were responsible for their care and survival, the reason why they're here on earth, right? And they failed them. They suffered abuse, physical abuse, sexual abuse from authority, parental figures. When you look at that dynamic, breaking it down, you begin to understand and see why and how they interact with their environment in the way that they do. When you look at normal, typical developing children, even normal, typical developing children sometimes may become oppositional, resistant, right, to parental direction and parental guidance. Normal, typical, right? Because as we develop, we gain a sense of autonomy. That naturally occurs, right? Where we're able to make our own decisions. That is needed for one's survival, for one's adaptation to the world. You know, yes, as babies, your parents oversee everything. They're responsible for your care. They make all the decisions. But as you develop, right, it's like it's a seesaw. And so the older you get, it's like the less control they should have over your decisions in life. And you begin to develop appropriate decision-making skills for the situation. Because you're going to grow up to become an adult, or they're not going to be there, right? You have to grow up and make your own decisions and be responsible, therefore, for your own behavior, right? But it's a balancing act. That process is a balancing act within normal developing children. So if you think of normal developing children giving pushback, resistance, right? When their parents say, you know, don't kick that chair, right? Don't do that. Stand here, right? And these are children who are well taken care of, so to speak, not abused necessarily, right? They grow up in healthy environments, and then there's pushback. Imagine when you layer that with abuse. by the very people who are responsible for that person's care, nurturing, love. They are being physically abused, extreme abuse. Like I said, first-degree burn, broken bones type of abuse, sexual abuse, repeat sexual abuse by their parents, by people who their parents left them in their care, right? Other family members. Think of a woman that's been sexually abused so many times. It made her numb. And naturally, she developed alters, right? Alters within her, as I used to say, multiple personalities to cope with the abuse, with the sexual trauma. She had to disassociate. Naturally, it's an adaptive mechanism that happens in the brain. The mind is a very powerful thing, but that's what naturally happens when a person undergoes severe amounts of trauma. They disassociate and develop these alters, right? She's one of my patients. I do individual therapy with her twice a week. And when we're talking about a person that's dealing with that degree of trauma, you must take a trauma-sensitive approach. It's just going to make things worse. And I'm going through the ward, right, these wards that I'm covering, and I see the way staff interact, and they're definitely not coming from a trauma-sensitive approach. Because it's like, if you had in mind that this person suffered abuse at the hands of their caretakers, right? And then we begin to talk about the power dynamic at play, right? They have a reason to push back, even more so, right? Like I say, if there's pushback in normal developing children as a healthy developmental response to them getting older, then even imagine times 100 what it would be for a child who suffered abuse from their own caretaker. How are they going to view authority, so to speak? These are people who are authority figures in this person's life, but this person broke that trust with that child. So they don't even trust authority. That's where I'm getting with this, right? So we wonder, like, how these diagnoses develop, especially those diagnoses that embody that characteristic of the individual having no respect for authority. Where did that come from? Not to excuse it, right? Because in order to be a well-rounded individual who's able to function healthily in this society, right? You have to have respect, right? Not only for authority, but the rules that authority enforces in order to so-called fit into society. But, they struggle with that, right? And so then there's medication. All the patients there are prescribed medication. All of them are prescribed antipsychotic and or psychotropic mood stabilizer medication. And, I'm giving an example where they're called for medication, right? Usually different times throughout the day. They offer medication like morning, afternoon, around lunch, evening, around dinner time. And so this is what I mean by having a trauma-sensitive approach. It's like, if and this is not just surrounding medication, this is surrounding any directive or any way of interacting with a patient. Obviously, given the type of setting that it is very restrictive, right? The doors are locked. The patients pretty much have to get permission to do everything, right? Like, every aspect of their life is controlled. And then taking into consideration the patients who suffer from having these impaired relationships with other people, having a poor sense of self, not trusting of authority figures for valid reasons, right? Having issues when it comes to control, the whole power exchange dynamic and control. This is why I've said before, like, I don't think that setting is appropriate. I think it can serve a purpose up until a certain point, but I think unfortunately, for a lot of those patients, they only get worse because, number one, the way it's set up, the structure of it is not conducive to their healing process, right? Everything is about a punitive approach, about discipline. They say, oh, everything's not about punishment. It is, though. You're contradicting yourself. I have to advocate for those patients there. For a patient to just even get crayons, non-toxic crayons, to use as a coping skill, to color, to draw pictures. Because everything is so controlled. And then they wonder why patients act out, right? It's like you have to really get to the root of the behavior to understand what's driving the behavior. And, that's obviously where I come in, especially me operating under the school of thought of being psychoanalytic, right? Of the psychodynamic approach. You have to get to the root of it. What is driving this behavior, right? What is driving the resistance? It's really about gaining a sense of empowerment, right? Of control. And unfortunately, these same staff, clinical staff, they get pulled into these enactments, right? Now, if you know that you're working with a patient who for them, a loss of a sense of control is a trigger. Why is it a trigger? Because for them in the past, when they were under their parents' care who abused them, that meant pain, that meant suffering. The two, they had learned, they had been conditioned, right? It's really about conditioning, classical conditioning, where they associate authority with abuse, with mistreatment, with maltreatment, with harm, with suffering, with pain. Not only authority, but alongside that, control, enforcement of rules. Do what I say. Lay down on the bed. Take off your clothes. Being forced to have sex with the very people who their care is entrusted to. So the thing about trauma, yes, it comes with triggers and there's warning signs. But then when they respond to their environment, things that trigger them, that may not necessarily be a trigger for the average person who doesn't have that history that they have, right? But for them, they react a certain way. So they may yell, right? They may become physically aggressive, start throwing things, doing whatever it takes for them to create a sense of safety. Is that appropriate behavior? No. Should that behavior be excused? No, right? But it's tricky when it comes to modifying behavior. And I think people, especially where I work, they think that what works for their children who are normal developing, for the most part, they think that the same approach works for these patients who suffer significant amounts of trauma. And I'm like, these are not your children, number one. So that behavioral approach is not going to draw the effect that you're looking for, you're seeking. It's not. You have to try a different approach. Trauma-focused approach. Trauma-sensitive approach. It's named that for a reason. And then they equate sensitive with babying or pacifying a pig. No. Right? But even if it is, think about that for a second. Even if it is babying them, what does that mean? To baby a person, to treat them what? Like a baby, like you would a baby? How would you treat a baby? Right? Nurture. Sometimes, unfortunately, it calls for that. Because these are, yes, they are adults. Where I work the facility is adults, starting at age 18 and up. But on an emotional, psychological level, are they adults? Oftentimes, many of them, they are not. They have developmentally regressed behaviors that you see. And so while their physical shell may be 18, 25, 35, 45, 55, deep down inside, there's a child that you're working with. Deep down inside, there may be a baby that you have to tap into. A 3-year-old child, a 2-year-old child, because that's where the abuse happened. And usually, wherever the trauma happened is where they're frozen at in time. Right? So yes, you may be looking at a 39-year-old woman, but psychologically and emotionally, she's a 9-year-old. Or she's a 4-year-old, because that's where her sexual trauma occurred when she was that age. So that's where she's frozen. And then it takes a skilled clinician, usually psychoanalysts, psychologists, to meet them where they are. Meet them at that level. It does wonders, y'all. It's like, it's magic. Because I'm willing to go there. And I think, obviously, when it comes to being an effective clinician, right? I mean, there are many different approaches. The most widely practiced is like CBT, right? And that's really for higher functioning people. People that don't come with all this baggage, right? And all this grit and grind, right? I look at CBT work is not something that you get in your hands and your feet necessarily dirty and wet. Like, it's a kind of clean approach, you know. It's well packaged, it's structured, it's manualized, you know. It works for a particular population. And I think, in fact, that when it was developed, we talk about CBT techniques and even DBT, which evolved from the CBT. It's like it was developed for a particular population, not black. We need our own approach. That's just fact. They try to adapt it for it to be culturally appropriate or culturally sensitive to different demographics of people. But those approaches ain't really for us. We're the ones who have dealt, not to say white people, other non-black people do not suffer from trauma. That is not what I'm saying. Our trauma is different, though. It is. And it requires a culturally competent and sensitive approach. It does. And when it comes to the approach that I embody, right? And especially on, just getting there. I think as I was saying, it requires a certain type of person who's very flexible. DBT is kind of like a cookie cutter approach. It's like the patient has to assimilate, to adapt. Whereas, when it comes to psychodynamic, it's called dynamic for a reason, because this is a interactional process that's happening. It's not that only the patient will experience change. It's like that change is dependent upon the agent, the psychoanalyst. There are many different psychoanalysts, theorists, who talk about themselves feeling different things happening in their body. It's an interdependent process. And it's where it gets deep. It requires another level of sophistication, right? there's a psychoanalyst that talks about feeling things in their body as cues for what the patient is feeling, even if it could be sexual things, right? Maybe you're not ready for that conversation. But I go I say that to say that it's a deep process. And it's a whole nother level, right? Psychoanalysts, first of all, get paid more than DBT therapists. I can say that for sure. And psychoanalysis can take place 5 days a week. It's very intense therapy. And obviously it requires a degree of training, specialized training. But the therapists themselves have to be willing to be there. It's almost like a sacrifice, right, that you're making. But it's not really a sacrifice if you're made for it. I don't really see it as a sacrifice. But it's a deeper level of work, beyond what CBT and DBT offers. Or even the behavioral approach, which CBT evolved out of the behavioral approach. Behaviorism is used to train dogs, freaking animals, right? Humans are not animals. We're not. That doesn't work. Offering rewards and punishment is not enough. It's not. It barely touches the surface. And the thing is, some of these patients will tell you, that's not even what I'm seeking. I don't care about no freaking Chinese food. I don't care about no pizza. I don't care that I'm not being allowed to get freaking snack. What I need is someone who has the time and compassion to understand me and to meet me where I am. So when I talk about meeting the patient where they are, and if they're at the point of a 3-year-old, it's meeting them where they are. It's a certain way you interact with the 3-year-old, different than you would act with a 25-year-old, right? It's a very nuanced thing, though. It's not like, oh, I can't get Google. No, it's not that, right? I've done it many times, right? Because I can see, I know my patients well enough where, because I'm very flexible, and I think that's what makes me a very good therapist, is because I can adapt. I've learned to adapt just naturally in my own personal life. I've had to do that, right? Personally. So it comes very effortlessly and natural on a professional level in my professional work that I do. And I'll have a patient that I'm working with who I've seen different alters come out within one session. I've seen this person exhibit different ages. They can go from being their actual age, right? Displaying attitudes, behaviors, thoughts, emotions that are consistent, right? This whole character that's consistent with their actual age. And then they go and regress to being a 4-year-old, a 3-year-old. And I'm on them because I'm so attuned to my patients, like I'm with them, right? And it's like a dance. It's like flowing with the sea. And I think that obviously that's what strengthens our bond, our relationship. I'm really good with my patients, My work speaks for itself, right? And they will tell you. That's why they send for me, they call for me to meet with them, sometimes even in crisis situations. And I go because it's about really getting them and meeting them where they are. And it can be difficult, I think, for other clinicians, like I say, who subscribe more to the behaviorist approach or subscribe more to the CBT approach, because those approaches kind of are cookie cutter. And the therapist who practices those approaches are more rooted in kind of the neutrality of who they are, right? In a sense that they don't necessarily adapt, to the patient or assimilate to the patient. If anything, they demand that the patient, change who they are so they can adapt and assimilate to the culture that the therapist is beholden to, essentially, right? So it's just like, no, you're not going to impact me. I'm impacting you kind of thing, right? I'm not going to change. I'm not going to be flexible. I'm not going to adapt. I'm not going to bend my rules, right? My approach, my techniques. No, my techniques are my techniques. And you're coming to therapy to learn these techniques. And if you can't, then to hell with you. That's, like I said, more for higher functioning people, right? Maybe, when I say higher functioning, these are people who are working professionals, right? But they still come with some symptomology that's characteristic of different disorders, right? It could be still bipolar, it could be borderline personality, it could be, depression, anxiety, but these are people who have jobs, they have careers, they may own businesses, right? They have families, like they are at a degree of functioning that can work for them. That don't work. It doesn't work. It doesn't fit, right? We're talking about individuals who suffer severe deficits on all different spheres, right? Of the spectrum, cognitive, psychological, physical, learning deficits. It's almost like you basically have to go into a position where you're raising a child, you're reteaching things. And that teaching comes by way more than just the techniques that you administer, but it's a relationship above everything, right? It's like almost adopting a child, even though they're an adult. It's like adopting them and reteaching them through that relationship, right? How to be in a way. And that obviously it's very time consuming. If you're listening to me, you're following me, it's very obviously, it takes time, it takes commitment, which a lot of people, they're not willing to be there to deliver. I like it. I like it. It's challenging, but I rise to the challenge in working with these individuals. And I'm not afraid, because like I said, my experiences have prepared me for this. I've been through a lot myself. So it's just like, I can identify with it. I don't run from it. Even in session, as I was saying, I've had patients who hear voices actively, are hallucinating, experiencing visual hallucinations, who are having conversations with their alters, right? And it's up for me to allow them to be. It's not a threat, and I think they appreciate that because they know, like, okay, she's not one of them scary clinicians. She don't just run, The issue, though, where I do work, a lot of people are very afraid of those patients. It's like, how can you be effective if you're so afraid? It's not to say you don't be cautious and vigilant, but show up and be there. And when you know a person, you know that just because they raise their voice doesn't mean they're going to hit you, right? They have the right to express themselves, even with elevated tone. And I'll allow them that space to do that. One of my patients who has different alters, who dissociates, in the conversation, she sometimes be doing this. Not the whole time, but there are times when she's just like, and we know what that means, right? In certain contexts, it's like, you ready to throw down. And she'll be looking straight face. And you know what? I don't budge. I sit there. I'm like this. I sit there and I'm looking at her, and of course I'm observing. Like, I'm always vigilant and I'm always ready to respond, but I'm sitting there, whereas I know other people, they get afraid, and they take that as a cue, like, we need to do something about this. And nothing ever happens. I say it won't, it can't happen, it won't happen, but it hasn't. It hasn't happened. Right? Because I know that's just her way of expressing how she feels. And she's feeling a certain way on the inside, and she has a right to feel that. If it's anger, that's her way of expressing anger, cracking her knuckles. Frustration, I meet them where they are, and I allow them that space. The thing about working with individuals with PTSD, borderline personality disorder, even dissociative identity disorder, but especially the first two, is like the enactment. Like, you can get pulled easily. And I think it's funny because I've seen it so much, like, with my colleagues, on my primary ward, and they get sucked in to the point where, like, they get over patients. Like, I'm over this person. When they say they're over them, it's like the compassion is gone. When they once cared and had compassion and empathy for this person, it's gone. They don't care, And it's just like, damn, that was quick. The patient ain't even been on the ward that long. Less than 4 months, 3 months, right? And your compassion is gone because you allowed yourself to get sucked into an enactment. What is that? It's the example I gave, right, at the beginning of this video, with my stepping into the field of mental health and the kid that threw the pillow. Had I got upset and angry, that would have been an enactment, right? And who's really in control? But I didn't. And that happens so many times. It's like these patients come clearly with their own set of problems. Staff do get triggered by these problems that the patients come with, and they take it personal, right? A patient may call the Justice Center because that's their coping skill or their protective mechanism that makes them feel safe. Because they suffer from significant amounts of trauma, they don't trust authority. They don't trust the setting of mental health, right? They've been abused not only before they got to the hospital, but at the hospital. They don't trust. There's no trust there. So what's their safety net? Picking up the phone and calling the Justice Center to file an abuse report on staff. And some may fluff it up, right? To the extent where their report becomes false. It's a false allegation. It could be partly true, but if you're exaggerating, it's false. And then, of course, how do staff respond? They take it personal. It's not about you, man. I said this. I had a conversation with patients who do that. I've talked to staff, who had the Justice Center calling them by pay. I say, whether they call in the Justice Center, whether they call you a bitch, whatever, like, you can't take it. Doesn't say you don't protect yourself now. Like, there was staff who actually got maybe punched in the face. Knock on wood. I haven't been hit. Knock on wood, okay? But I have not been physically assaulted. And it'll be 2 years that I've been working there at that particular facility in December. This December coming up. I have not been assaulted. Physically assaulted by a patient. But I get it. It's just like, yeah, you want to protect yourself, right? So this is like self-preservation, the way sometimes staff respond. They create a distance between themselves and the patient. They become distrusting of the patient. They lose empathy and compassion towards the patient, therefore negatively impacting their rapport, their relationships. So it's like, how can you really be of service? You're really not. You're kind of being of service at a distance, so to speak, in terms of the documentation that you do or the paperwork that you may do on the patient's behalf. But apart from that, relationally, you're not really of any benefit to the patient at that point. And yes, that could serve a purpose too in the staff creating that distance so that person, that individual sees that this is kind of like a natural response. And I tell the patients all the time, like, what transpires here in this small, enclosed, restricted context is a microcosm of society, right? You see many different flavors of staff, how they present. You know, some are kind of grounded and rooted just in their own personality. Professionalism aside, right? You get in the real deal. How this person is, which is a representation of how people are in society. And if your end goal is to transition into society, then you're getting a taste of that, right? This is the experimental stage, the process where you could learn how to interact with people who are representations here of the people you're going to see in society. So if you go and make a report, which turns out to be false, on staff, and then therefore that staff shuts down, they're not talking to you the way they used to talk, they're not even exchanging smiles with you anymore, right? That's what you're going to get. Actually, may get worse. You might get your ass beat in society, right? You know, the thing, staff really can't retaliate, obviously, for obvious reasons, on a patient that does that, or anything remotely close, right? That's offensive or potentially threatening to the staff. They can't retaliate, right? But in society, it could cost you your life. You can get injured very badly. And even in that particular context, if you do that to another patient, patients, they'll fight each other back, right? You may get sent to the hospital, right? So some things are just natural responses, naturally occurring responses to behavior that you choose to take responsibility for or not. But taking it back to having a trauma-centered, trauma-focused approach, I just think that's very paramount. It's so important. I don't think it's practiced enough. And looking at just the culture of that particular place where I work, you know, most clinical staff aren't coming with that approach. And it feels like a prison, because I worked in a prison setting and I practice trauma-focused approach because that's just me. But in a prison, they're not practicing that. It's punitive approach. They're like, hey, look at that. Listen, you're an adult. You know what the hell you're doing, right? And therefore, it's operating under the choice theory paradigm. You choose the choice, then you choose the consequence. This is a consequence of your choice. You want a different outcome, different consequence, then make a different choice, right? Point blank, period. That's just how it is in the prison system. But I mean, it's just insane just how, you know, these patients deteriorate, you know, with this approach being implemented where I work. It causes harm. You can see it, like it's not moving the patient forward, right? If anything, it's causing more harm to them. And that's where it becomes problematic. So I'm going to wrap this video up here. I can come back to do a part 2. For those who are watching this video and you do work in the field of mental health or in the context of the healthcare system, and you know you can relate to what I'm saying, feel free to drop your comments below. If you have questions, feel free to drop those below. You can share this video, and I will catch you guys in the next one. Today is actually the LGBTQIA Pride Festival Parade here in New York. I think it's supposed to start at 12 o'clock, so it's probably already started. I am going to make my way down to Lower Manhattan. No, I don't identify myself as LGBTQIA, but I do identify myself as sex positive. So yeah, I like the energy. I think it's just about the spirit of the holiday, or, you know, the spirit of the celebration that's happening, you know, just standing tall and firm in one's identity, irrespective of what society tries to impose onto people and how we should be or who we should be. I'm all for that. And so, yeah, I'll catch you guys later. Love you guys. Bye.